Hello everyone, I'm Dr. Juma Bishwas. Today I'm going to present second part of the management of unscheduled bleeding on hormone replacement treatment. So today I'm going to discuss the investigation and the management part of this topic. So we need to know that when we need to investigate when patient come to us with this problem. So any unscheduled bleeding within 6 months of starting of the HRT or 3 months after the dose or the preparation changes, this kind of bleeding is quite common. So we just need to assure them we can adjust the progesterone or HRT for the 6 months. Unscheduled bleeding, if it is persist if after 6 months of adjustment, or the first bleeding presentation more than 6 months after starting of the HRT or 3 months after changing of the HRT. In that situation, they definitely need an urgent ultrasound assessment, and that should be within six weeks time. Any prolonged bleeding or heavy bleeding or two minor risk factor for endometrial carcinoma, in that situation, they also need an urgent ultrasound scan, and that's also within 6 weeks time. But along with this problem, if any woman come to you with one major or three minor risk factor for endometrial cancer, they need an assessment through urgent suspicious of cancer pathway, that is within 2 weeks time. So you can see here, so any persistent bleeding for even after adjustment of the HRT after 6 months, or after 6 months of starting of the HRT, or within 3 months of changing of the dose or the type of the HRT, or any prolonged or heavy bleeding or two minor risk factor, in that situations we can do an urgent assessment within 6 weeks time. But unscheduled bleeding with one or three minor risk factor, in that situation they need 2 weeks pathway urgent assessment of endometrium. So when to refer for the urgent ultrasound? So that gonna be within 6 weeks times. As I mentioned, prolonged withdrawal bleeding, heavy bleeding or persistent bleeding, or two minor risk factor for endometrial cancer, more than 6 months after starting of the HRT. That means bleeding with continuous combined HRT after amenorrhea, or unscheduled bleeding on sequential HRT after light regular withdrawal bleeding, they needs within 6 weeks time urgent ultrasound assessment. Within 2 weeks time, if unscheduled bleeding with one major or three minor risk factor, they need urgent assessment within 2 weeks time. So how should unscheduled bleeding be investigated? We already know that by ultrasounds, and the cutoff for thickness of the endometrium is for sequential HRT is less than or equal to 7 millimeter, and for the continuous combined HRT is less than 4. So that's very important to remember. So if the patient is already in sequential HRT, less than 7 is the cutoff, and for continuous combined HRT is less than 4. So if you see the thickness is like that, then we just reassure them, and we just offer them to readjustment of the HRT for the 6 months. But if persistent bleeding or if it become heavy, then we can do an urgent assessment. Any thickened endometrium, that means if they are in continuous combined HRT more than 4 millimeter thickness, or if they are in sequential HRT, and if it is more than 7 millimeter, they need an endometrial biopsy. Endometrium, if it is not fully visualized on the transvaginal ultrasound, but within normal limit, they also need an urgent endometrial assessment, that's within 6 weeks time. Other than that, endometrium is more than or equal to 10 millimeter without any unscheduled bleeding. If they have any major risk factor, they also definitely need a biopsy. If an absence of unscheduled bleeding more than 4 millimeter with a continuous combined HRT, or more than 7 millimeter with sequential HRT with one major, two minor risk factor, they also need an assessment. That means without any bleeding, even if they have thickened endometrium with one or two minor, one major, two minor risk factor, they also need an assessment. So if you can see here, it's very clearly mentioned, like with a continuous combined HRT, less than 4 millimeter is the cutoff. So if you see the thickness is like that, you just need to assure them more than 4 millimeter in case of continuous combined HRT, they definitely need endometrial biopsy. For the sequential HRT, if their cutoff is less than 7, so if it is more than 7 millimeter, they need endometrial assessment. Incomplete endometrial assessment, but visualization of the endometrial thickness within normal limit. They also need an endometrial assessment that can be within 6 weeks time. But thickened endometrium, in that situation, they need within 2 weeks time endometrial biopsy. So the time is very important, and also the thickness is very important. You have to see the thickness, you have to see the time as well. For continuous combined HRT, more than 4 millimeter within 2 weeks time biopsy, sequential HRT, more than 7 millimeter biopsy, incomplete endometrial assessment, but the normal endometrium thickness, they can be within 6 weeks time. And we also know, like, if without any bleeding, if the endometrial thickness is more than equal to 10 millimeter, or without any bleeding, if it is thickened endometrium with one major, two minor risk factor, they also need an endometrial biopsy. So this is very important to remember these things. So now we have to manage according to the endometrial biopsy report. So usually in case of unscheduled bleeding with thickened endometrium, we can take the endometrial biopsy in a two-way. One is either by blind outpatient biopsy, that can be Bartle biopsy, or one can be by the hysteroscopy directed biopsy. So for normal blind biopsy, in that situation, you can just assure them and can adjust the progesterone for 3 months. If it is persistently bleeding, or if it is very heavy, in that situation, you can assess hysteroscopy and biopsy within 6 weeks. Normal hysteroscopic biopsy in that situation, as because it's very accurate, in that situation, you can wait longer than a normal blind biopsy. So it's going to be 6 months. So for the normal blind biopsy, you can wait up to 3 months. And for hysteroscopic biopsy, you can wait up to 6 months. Thickened endometrium on transvaginal scan, but it is when you take a blind biopsy, if it shows that is insufficient sample, in that situation, you definitely need an hysteroscopy within 6 weeks time. On blind biopsy, if you see it's proliferative endometrium, but they also have risk factor for the endometrial cancer, like one major, two minor risk factor, and they are in continuous combined HRT, they also need an hysteroscopy. If they have any hyperplasia with atypia or endometrial cancer reported, based on that, you have to manage and you have to tell them to stop the HRT. So this is the way you have to manage based on the histology. So if you see normal biopsy, wait for 3 months, assure them. If it is hysteroscopic biopsy, wait for 6 months and assure them. If you on the blind biopsy, if you see insufficient sample, then you can offer them hysteroscopy and within 6 weeks. But if you see on the hysteroscopy, the lining of the endometrium is atrophied and thin, and it is insufficient sample on the biopsy, you can assure them actually. Proliferative endometrium on the blind biopsy with the risk factor, and they are already in continuous combined HRT, they also need to offer them hysteroscopic biopsy. Other than like any kind of pathological report like hyperplasia with atypia or endometrial cancer, they need to stop the HRT, and based on the report, they have to manage. It's very nicely written, the recommendations of the management based on the biopsy report. And it's very nicely explained how you're gonna manage any unscheduled bleeding on the HRT. So you can see that you have to assess the risk factor, bleeding pattern, also you have to take the detailed history of the HRT. You need to do an examination and investigation. You have to find out whether they have any risk factor. If they don't have any risk factor, like only two minor risk factor, or there's no major risk factor, or less than three minor risk factor, in that situations, you just need to optimize the HRT for 6 months. And then you need to see that whether their bleeding pattern is improved or not. If bleeding increasing or persistent, they need an urgent ultrasound within 6 weeks time. If the bleeding pattern improve, but still they have ongoing bleeding after 6 months, or no improvement in intensity frequency during the 6 months, in that situation, we can discuss with them about the options, like to stop the HRT versus non-hormonal alternatives. And if the patient decision to stop the HRT, if it is yes, and then also you need to see, if you see that still after stopping of HRT for 4 weeks, still they have bleeding, In that situation, they also need an urgent endometrial assessment. And you can also see, like uh, even like more than we know that within six months of starting of the HRT, or within 3 months of changing of the type or the dose of the HRT, there's a chance of bleeding. But if it is more than that duration, definitely they need an urgent transvaginal scan. One major or three minor risk factor, yes, they definitely need urgent endometrial assessment. That is going to be within 2 weeks time. We also need to see the cutoff of the ultrasounds, and endometrial thickness. If it is sequential, more than 7, or continuous combined HRT more than 4 millimeter, or endometrium is incompletely visualized, in that situation, they need a biopsy. But if it is normal, in that situation, we have to optimize the HRT for 6 months, and then you have to assess. If you see there's a persistent bleeding or there's a heavy bleeding, definitely they need an endometrial assessment. So it's very nicely explained how you're gonna manage a woman with unscheduled bleeding on HRT. So these are the basic principle you always need to remember when you are prescribing HRT to reduce the any kind of incidence of unscheduled bleeding. So firstly, you have to make sure that they are compliant with the doses and also the type of the HRTs. And always consider and combine patch twice weekly or daily pill to for easier use, so that they can remember that one. Product use is very important. You have to make sure that they understand the correct use order of the pill and patches, and they are applying the topical products properly. Progesterone dose should be matches with the estrogen. Use of the sequential HRT for the perimenopausal and continuous combined HRT for the menopausal woman, or those with prior ablation or amenorrhea with contraception. That's also very important. So, see, for the sequential HRT, you have to remember that for the perimenopausal woman, and for the continuous combined HRT, that for the menopausal woman. And also, you need to start the lower dose of HRT, and you have to optimize the dose also along with the BMI and also with the medical comorbidities. You can offer vaginal estrogen or the moisturizer if you see there's an atrophic vulvovaginitis. Mirena to all women with uterus at an initial HRT consultation if appropriate, unless there is a contraindication. So Mirena should be the first line progesterone you can offer. But you also need to look on contraindication, like whether there's an uterine malformation or large fibroid or history of any trauma or ablation. Any high risk of endometrial cancer, in that situation also we can offer them progesterone, especially Mirena. If patient need contraceptions, we can also assess that, and we can also offer them to prevent any kind of unplanned pregnancy. If the patients with sequential preparations and having unscheduled bleeding, in that situations, it's mostly common with the perimenopausal woman, because HRT doesn't suppress the ovarian activity like contraception. So that's why this kind of bleeding is very common. For managing, we can give them a time sequential preparation that can coincide with the natural cycle, like estrogen on day 1 and progesterone on day 15. We can consider dejogestrel with HRT, or we can consider combined oral contraception pill if it is less than 50 and they have low risk of thrombosis. Then that can also suppress the ovarian activity. Non-combined preparations we can use, like use progesterone 2 weeks on and 2 weeks off to reduce the error. Oral HRT may result in higher amenorrhea rate than sequential HRT for the woman less than 55 and lower thrombosis risk. We can adjust the dose of the progesterone. We can give them extra progesterone for 3 months if there's bleeding occur, like micronized progesterone 100 milligram or 10 milligram medroxyprogesterone acetate or 5 milligram of norethistérone. We can add along with the HRT. If 5 milligram norethistérone causes side effect, we can also use them, give them 3 Noridate tablets for 10 to 14 days with low or standard dose estrogen. If they have spotting before withdrawal bleeding, we can increase the estrogen dose, and that should be also adjusted with the progesterone dose as well. Reduce the estrogen dose uh, uh, and we can also offer them some non-hormonal alternatives like lifestyle changes, complementary pharmacological treatment. If they're in continuous combined preparation and having this kind of bleeding, so we can offer them to switch to sequential HRT if they have periods within the past 1 year. And when we are switching from sequential HRT to continuous combined HRT, we have to give them 1 month period time to wash out their HRT from their body. Lower dose of HRT needs to be started, especially if the woman is more than 60 with mild syndrome. Micronized progesterone they can use daily to reduce the administration error instead of giving 1 to 25. We can increase the progesterone dose, or we can change the type of the progesterone. That also can help. Mirena is the first line. It should be offered unless there is any contraindication. If there is any new unscheduled bleeding occurs after 4 years of using of Mirena, in that situation, we can offer them to change the Mirena preparation. Oral HRT may achieve higher amenorrhea rate, but oral preparation also having a risk, especially for the woman more than 60 years. So we have to decide the risk versus benefits. Non-hormonal alternatives we can also offer them if they're still having bleeding with a continuous combined HRT, like lifestyle management, complementary or other non-hormonal pharmacological treatment. Consider switching to the sequential regime for 6 to 12 months if bleeding persists despite of adjustment. We can also think about that. And we can also reduce the estrogen and we can offer them some non-hormonal alternatives. Others, last case scenario, we can also offer them surgical management if there is any kind of submucosal fibroids, like we can offer them hysteroscopic myomectomy. We can offer them endometrial ablation, especially with the recurrent unscheduled bleeding. Um, Hysterectomy is the last options, especially if they have persistent bleeding with the HRT. Even after stopping of the HRT, they have the bleeding. This is gonna be the last option. So thank you all for listening to today's presentations. Very soon I will also publish another video related with the adjustment of the progesterone dose along with the dose of the estrogen, and also the different modalities of the HRT I'm going to discuss over there. So keep an eye on my YouTube channel, and if you have any questions and query, I'm happy to answer all of your questions and query. And please comment on the comment box and give me some feedback so that I can improve my videos.